Hi friends, I am Dr. B.D. Rao of Usha Clinic and founder of the websites viewmedicaldoubts.blogspot.com and .com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the medical termination of pregnancy. In the recent years, there has been great change in the obstetrician's attitude towards the induction of termination of pregnancy necessitated by changing society, socioeconomic factors, and population explosion. Pregnancy now can be legally terminated when the continuation of pregnancy would involve serious risk to life or grave injury to the health, whether physical or mental, of a pregnant woman either before or after birth. There is substantial risk that if the child was born, it would suffer from such physical or mental abnormalities as to be seriously handicapped in life. Pregnancy resulting from rape, intercourse with an unmarried girl under the age of 16, or intercourse with a mentally defective woman. Pregnancy resulting from contraceptive failure. Techniques of termination of pregnancy. Termination of pregnancy can be performed in different ways. The duration of pregnancy is the important factor. Termination before 12 weeks is surgically a very different operation from that in the second trimester. So the patients are divided into two groups: low risk groups, which include healthy women into 12 up to 12 weeks, and high risk groups include all later terminations and those classed as therapeutic abortion. Low risk pregnancy. To decide the termination, clinical history is taken, pelvic examination is performed, and future family planning methods discussed. Whatever the method is employed, it is important that the procedure is explained to the patient and cooperation is obtained. Termination of pregnancy can be performed under local, general, or spinal anesthesia. Before 8 weeks, routine pre-medication with 5 milligrams of intravenous diazepam or other tranquilizer may be useful in anxious patients. Local anesthesia is usually preferred. Local anesthesia can be carried out by cervical block with bumpacid lignocaine. The injection should be made at the junction of cervix and vagina. A total of 10 ml is injected at 4 and 8 o'clock positions. Some may prefer to give injections at 3 or 4 positions. Sometimes general anesthesia may be required. Before 8 weeks, vacuum aspiration can be performed without cervical dilatation and therefore without anesthesia. If dilatation is necessary, paravertebral block lessens pain from post-evacuation uterine contraction. Operative procedure: dilatation and curettage. D and C. Infections in the cervix should be treated prior to the operation. After passing urine, the patient is placed in lithotomy position. Bimanual examination should be carried out to determine the size and position of the uterus. The cervix is then exposed by a SIM speculum or a domed bivalve speculum. Either a single toothed tantalum forceps or a sponge holding forceps is used to hold vertically the anterior lip of cervix with the lower point inside the arms. The, the uterine sound is passed to determine the depth of the uterus. The cervix is dilated to a size to accommodate the cannula to be used for evacuation. The choice of the cannula is determined by the duration of gestation. Generally, 4 to 8 mm dilators are used for 4 to 7 weeks of gestation. 9 to 13 dilators for 8 to 10 weeks of pregnancy. 11 to 14 dilators for 10 to 12 weeks of pregnancy and over. The extent of dilatation is equal to zero point 0.5 to 1 of or more than cannula used. Following dilatation, a curate ovum forceps or sponge holding forceps placed is passed through the cervix. The membranes are ruptured and some part of the conception removed to include uterine contractions. Up to 10 weeks, initial curettage is preferable, following by the use of ovum forceps to remove the detached placental tissue and fetal parts. In later pregnancies, the ovum forceps may be used first in order to extract the fetus and parts of the placenta. When no more large pieces of material can be removed, the uterine cavity is curetted carefully. On completion of the operation, a bimanual examination is done. When the uterus is empty, the stone should be formed and bleeding slight. A poorly contracted uterus or persistent bleeding should suggest incomplete emptying and curettage is repeated. A long-acting oxytocin has 0.2 to zero point 0.5 milligrams of methazine or ergotamine may be given intramuscularly after dilatation and before curettage or vacuum aspiration. Vacuum aspiration, suction evacuation, SE. It is a quick and efficient method of emptying a pregnant uterus up to 12 weeks. It is now the most commonly used method. Different vacuum aspiration pumps or various makers are available. There are manually operated and electrically operated ones. Once they are large syringes, also there are large syringes which could provide the necessary vacuum for evacuation in very early pregnancy. The pump used should be capable of delivering a constant negative pressure of not less than 600 of mercury. Anything less is incompatible for this technique. It is important to ensure the pump is constructed to suck and not to blow air into the uterus. The cannulas used range in their diameter from 4 to 6 to 10 or 12 mm. Usually the tip is slightly angled and the hole may be placed terminally or subterminally. Most cannulae are made of metal, but plastic cannulae are also available. The metal cannulae are sterilizable and used repeatedly after autoclaving, while the plastic are pre-sterilized and disposable. After the required dilatation, the chosen cannula is introduced to the full depth of the uterine cavity. When suction is applied, the cannula is moved back and forth, rotating through 180 degrees within the uterine cavity until the entire uterine cavity has been reached. Alternatively, the cannula can be introduced into the fundus and slowly withdrawn as the uterus contracts around it. The operator will note a characteristic grating sensation when the uterus is completely emptied. This feeling and appearance of only air bubble if transparent cannula are used indicate that the evacuation is completed. Once the evacuation is complete and the cannula removed, the uterine cavity may be further explored with a curette to make sure that it is empty. Check curettage. Complications. Immediate complications. Perforation. Perforation of the uterus and hemorrhage. If perforation is diagnosed and systemic effects are manifested, laparotomy and repair of the tear or sometimes hysterectomy is indicated. If perforation is small, can be treated by conservative measures, observation, and antibiotic therapy. Delayed complications include infection and post-abortal bleeding due to incomplete evacuation. Curettage stops the bleeding. Advantages of vacuum evacuation. Vacuum evacuation has some advantages as there is less bleeding, less perforation cases, more complete evacuation of uterus, quicker process. Patient can be dealt with on an outpatient basis. The patient could go home after the process. Sequelae. Long-term complications are rare. Infections as cervicitis, endometritis, parametritis, and salpingo-euphoritis are reported in some patients. There may be premature births in subsequent pregnancies. Termination and sterilization. Up to 10 weeks, a tubal ligation by vaginal route can be performed in usual way or through coldoscope. After 10 weeks, by laparoscopy or laparotomy is required. Laminaria tent. These are made of seaweed dried and rounded into a stick-like shape which is intensely hygroscopic. When placed in moist environment as cervical canal, gradually swells to several times its original diameter over 6 to 12 hours period, dilating the cervix in the process. Laminaria tents comes in 5.5 to 6 centimeters in length and 3 diameters. Small 3 to 5 mm, medium 6 to 8 mm, and a large one 8 to 10 mm in diameter. A thread is placed at the end of the end to facilitate removal. The tents after sterilization are inserted the day before abortion and left in place overnight. The chosen size depends upon the degree of dilatation required and the size of the cervical canal. Care must be taken to insert the distal tip of the tent through the terminal cervical os, while the proximal tip remains outside the cervix to facilitate the removal. After the removal, the uterus can be emptied either by aspiration or by curettage. Mild uterine cramps are experienced by many patients after insertion, but the analgesics allay the pain. If the patient do not return after 24 hours, serious problems may arise. No patient with a tent should be left to follow up. High-risk pregnancies. Pregnancies in women in the first trimester of pregnancy who have medical complications as cardiac, renal, etc. should be terminated by vacuum aspiration or dilatation and curettage. Such terminations should be carried out only in institutions as in patients, as in as inpatient procedures only. Several methods are available for termination of pregnancy in second trimester, but all have serious disadvantages. Some of them will be briefly discussed here. Intraamniotic installation. Intraamniotic injection of hypertonic saline is widely employed. Under aseptic precautions, a medium-sized needle is passed through the abdominal wall into the uterine cavity, and up to 200 ml of 20% saline solution is instilled into the amniotic cavity. The procedure is stopped if blood instead of amniotic fluid is obtained at amniotomy. The amount of saline also varies. This procedure is performed after 16th week. General anesthetic should not be used. Spontaneous abortion occurs in 12 to 48 hours. In about 25% cases, the abortion may be incomplete and curettage may be necessary for completion. Hazards. Hazards include solution infused may enter the vascular system or abdominal cavity by error. It may lead to cardiac failure or cerebral edema or renal shutdown due to electrolyte changes. As an alternative, hypertonic dextrose also terminate the pregnancy. Prostaglandins. Prostaglandins like PGE28, PGA29, PGF29 and their methyl analogs have been found to be very useful in termination of pregnancy. They can be administered in different ways as intravenous, intraamniotic, extraamniotic and intravaginal. Intravenous and intraamniotic routes have many side effects like diarrhea, vomiting, palpitation, etc. The current trends favor extra-amniotic installation by vaginal route through Foley's catheter passed through the cervical canal and placed extra-amniotic in the uterine cavity. In one schedule, PGF2A in 50 milligrams dose is injected intraamniotically. 2.5 milligrams of 15 methyl PGF2A is also tried out. Such installations have been combined with oxytocin drip also. Rivinol. It is an aniline dye when injected extra-amniotically gives rise to abortion. A 0.1% solution is injected through the Foley's catheter placed extra-amniotically. 10 ml of solution for every week of pregnancy is the dose employed. Very favorable results are reported. Unlike prostaglandins or hypertonic saline, it is free of side effects. Ethacridine lactate. It is a similar compound. Abdominal hysterectomy is employed as a method of termination of pregnancy in second trimester. If agreed to, tubal sterilization can be done at the same time but associated with mortality. Menstrual regulation. This is a promising method of fertility control which involves vacuum aspiration of uterus within few days of delayed menstrual period. It is also known as the endometrial aspiration, which implies intervention before pregnancy is established. A small plastic cannula, Carmen catheter 6 mm is inserted through cervix into the uterus. The operator then applies vacuum at the proximal end of the tube, thus aspirating the lining of uterus which normally be shed in menstruation. The vacuum source usually used is a syringe of varying capacity. Advantages: simplicity of the process, safety of the system, minimal side effects and complications. No anesthesia of any type is required. Equipment is simple and inexpensive and takes only few minutes. It is an outpatient procedure. However, the patient may not be pregnant as it is not practical to do pregnancy test in such early period. Induction of abortion after 12 weeks of gestation is risky. If the woman is not sterilized at the same time or does not practice contraception, there is evidence that half of them become pregnant. Even in the hands of specialists, large-scale abortions have a certain amount of risk by perforation, hemorrhage, or infection. Late sequelae include menstrual disorders, chronic pelvic pain, euphoria, or emotional disturbances. That's all about medical termination of pregnancy, and in the next video I will discuss about some other disease. Thank you.